We've done a little switching here, and we'll call our second panel witness up. This panel includes Mr. Paul Perrault, the president of CSL Biotherapies Incorporated, Dr. Vas Narasimhan, hopefully I said that right, is president of Novartis Vaccines USA. Dr. Ben Mikosha is executive vice president of operations for Medimune. And Dr. Philip Hosbach is Vice President of Immunization Policy and Government Relations for Sanofi Pasteur. Dr. Lakey is Commissioner of the Texas Department of Health Services. And Dr. Jeffrey Levy is Executive Director of Trust for America's Health. I welcome all of our witnesses testifying here today. In accordance with the policy of the Oversight and Investigation Subcommittee, witness testimony will be taken under oath. Please be advised that under the rules of the House, you have the right to be advised by counsel during your testimony. Do any of you wish to be represented by counsel? Everyone's shaking their head no, so I'll take that as a no. Therefore, I'm going to ask you to please raise your right hand to take the oath. You swear or affirm testimony you're about to give to be the truth, the whole truth, nothing but truth, matter pending before this committee. Let the record reflect the witnesses have replied in the affirmative. You're now under oath. We will now hear a 5-minute opening statement from each of our witnesses. You may submit a longer statement for inclusion in the hearing record. Mr. Perrault, we'll start with you. And for 5 minutes, please, sir, your opening statement. Mr. Perrault, you might want to pull that mic up and make sure the green light's on, a little button there.
There we go.
There we go.
All right.
And we'll start the clock. We'll be all set. Go ahead, sir.
So good afternoon, Chairman Stupak and Chairman Pallone, members of the committee. I'm Paul Perrault, president of CSL Biotherapies Incorporated, the U.S. distributor of influenza vaccines manufactured by our parent company, CSL Limited, located in Melbourne, Australia. Pleased to be here today to discuss our experience in manufacturing the H1N1 vaccine, specifically for the United States. CSL Biotherapies believes it is important to understand how the government and industry can best work together to help assure vaccine availability for influenza pandemics. I want to ensure this committee that CSL Biotherapies is committed to providing the entire amount of both the H1N1 bulk antigen and the finished vaccine doses that we have agreed to in our contract with the Department of Health and Human Services. We take the H1N1 pandemic very seriously and have been a leader in developing and delivering vaccine to combat this virus. CSL has manufactured vaccines since its founding in 1916. Our world-class influenza vaccine production facilities have the capacity to produce up to 80 million doses of trivalent seasonal influenza vaccine annually. Our seasonal flu vaccine, Afluria, was launched in the United States in October 2007 and indicated for ages 18 and above. And as you heard Dr. Goodman state last week, Afluria and our H1N1 vaccines received FDA approval for administration to individuals 6 months through 17 years of age as well. Afluria and our H1N1 vaccine come in multi-dose vials and thimerosal-free pre-filled syringes. CSL initiated the Western world's first human trials with the 2009 H1N1 vaccine and published our research findings in the New England Journal of Medicine, demonstrating the efficacy of a single 15 microgram dose. These data, along with the results of clinical trials in infants and children, were communicated rapidly to regulatory and public health authorities in the United States and globally, recognizing their value to public health decision-making. In May 2009, HHS and BARDA approached CSL Biotherapies to inquire whether we might be able to provide an H1N1 vaccine for the United States. CSL Biotherapies entered into a 1-year special contract initiated on May 28, 2009, to provide 36 million dose equivalents of H1N1 bulk antigen to the United States government. CSL Biotherapies did not have a previous pandemic contract with the United States government. As part of the agreement signed in May, CSL Biotherapies made it clear that the company had a pre-existing contractual obligation with the Australian government to provide vaccine to that nation first should WHO declare a pandemic. I want to stress that this had no impact on fulfilling our schedule submitted to BARDA. On June 1, 2009, CSL received the first H1N1 virus vaccine seed from the New York Medical College. The yields from this lot were approximately 1/3 to 1/2 of the average H1N1 seasonal influenza yield. As a result of these low yields, CSL formally communicated to BARDA a delay to the overall timing of the H1N1 bulk antigen delivery. On the 18th of August, CSL received a new vaccine, virus C, that was introduced into the manufacturing process. Yield improvements in excess of 80% compared to the previous seed were observed. A revised supply schedule was sent to HHS on September 14th, incorporating production on this seed lot. CSL remains committed to maximizing the yield and availability of H1N1 vaccine. CSL has invested in fill and finish capabilities in Europe and Kankakee, Illinois, to improve the availability of influenza vaccine. The Kankakee facility has achieved licensing of its new state-of-the-art syringe fill and finish line this past September. I would like to recommend measures to help assure availability of pandemic vaccine. First, I would recommend there be a focus on producing a greater assortment of influenza seed lots earlier that can be utilized in the creation of future pandemic influenza vaccines. The poor yields resulting from the first available seed lot had a significant effect on reducing the amount of available H1N1 vaccine. If the 10-week gap in identifying the second higher-yielding seed lot could have been avoided, higher output could have occurred sooner. Second, new adjuvants can help to enhance the immune response and reduce required dosing, which would make more antigen available for additional vaccinations. A supportive environment for development of new adjuvants with influenza vaccine could facilitate in this advancement. Finally, more education about the benefit of influenza vaccination and the achievement of higher vaccination rates closer to CDC recommendations would help to prevent influenza and support readiness. Our passion at CSL Biotherapies is to help save and improve lives, and we wish to do our part in protecting the United States population from H1N1 and seasonal influenza. We'll continue to work with the government collaboratively. Thank you for the opportunity to speak before the committee, and I welcome the opportunity to answer any questions.
Thank you. Doctor, would you like to testify? Pull that up and turn that mic on, please.
Thank you. Good afternoon. I want to thank Chairman Stupak, Chairman Pallone, Ranking Member Walden, and the distinguished members of the committee for the opportunity to speak with you today. Novartis Vaccines and Diagnostics is a leading global vaccine manufacturer headquartered in Cambridge, Massachusetts. Along with our predecessor companies, we have been a leader in the development and supply of influenza vaccines to the United States for over 25 years. Today, I would like to highlight to the committee Novartis Vaccine's commitment to U.S. influenza pandemic preparedness and our dedication to help prevent every possible illness and death from influenza. We commend HHS for its global leadership in pandemic preparedness over the past 5 years. We have had a broad and successful partnership with HHS, including active collaborations on cell culture vaccines, adjuvants, stockpiles, and new production facilities. Novartis Vaccines has committed approximately $1 billion in influenza vaccine development and production since 2006. Importantly, with HHS support, we are constructing the first flu cell culture manufacturing facility in the United States, located in Holly Springs, North Carolina, and with its ribbon cutting later this month. This facility will help ensure the rapid availability of pandemic vaccine for the American people in the future. For this pandemic, we have continued our commitment to U.S. pandemic response and public health. First, in May, we voluntarily dedicated the entire vaccine output from our manufacturing facility in Liverpool, England, to the United States. This facility represents over half of our global egg-based manufacturing capacity. We did this because of our long partnership with HHS, foregoing the potential opportunity to quadruple the output of this facility using our MF59 adjuvant. Second, our entire organization has worked around the clock to support U.S. vaccine production. We've made large new investments, added 300 additional staff, accelerated new production lines, and have been operating our production facility with a high level of quality and efficiency. Third, we rapidly started and enrolled a broad range of clinical trials in more than 9,000 children and adults in less than 3 months. Our data showed in early September a single dose as opposed to 2 is adequate for adolescents and adults, and we recently showed that a half dose might be sufficient. Fourth, we have prepared for HHS to use our MF59 adjuvant that is currently licensed and being used exclusively in our products outside the U.S. for H1N1. We have demonstrated in recent U.S. pivotal clinical trials that our adjuvant could significantly increase U.S. H1N1 vaccine supply. Fifth, we successfully supplied 27 million doses of seasonal flu vaccine to the U.S. by early October. Now, most importantly, in partnership with the U.S. government, we have overcome tremendous challenges to produce a safe and effective pandemic vaccine in less than 3 months. These challenges have included low yields, multiple production uncertainties, and compressed timelines. Despite these challenges, as of today, Novartis Vaccines has shipped over 18 million unadjuvanted doses to the U.S. government, and we are fully on track with our production, a tremendous joint accomplishment. We also believe, based on the experience this year, there are important opportunities to improve pandemic preparedness in the future. These opportunities include the need to move manufacturing into the 21st century for influenza vaccines using new technologies, such as our cell culture-based technology now being used, licensed for seasonal and pandemic use in Europe. There's a need to accelerate regulatory pathways for novel influenza adjuvants and pandemic vaccines. We need to develop new testing methodologies to speed up vaccine formulation and quality release, which can often slow down vaccine availability. We need to maintain the strategic national stockpile for rapid deployment in the case of a severe pandemic. And finally, as noted by other members, we must support seasonal influenza vaccination demand to ensure that suppliers are not forced out of the market, as has happened in the past. Novartis Vaccines continues to do everything possible to maximize the rapid supply of a safe and effective vaccine in close collaboration with HHS. We believe that when taken into full context, the productive public-private partnership to produce, test, and deliver a safe and effective H1N1 vaccine to the U.S. has been a remarkable success. We are fully committed together with HHS now and in the future to ensure we achieve our shared goal of preventing every influenza case in the United States. Thank you. I welcome your questions.
Thank you, Dr. McKelson. Your testimony, please. Turn the green light on and blow it forward. Thank you.
Okay. Chairman Stupak and Pallone, ranking members, Walden and Dune, members of the committee, thank you for the opportunity to address you today. My name is Ben Magilse. I'm the Executive Vice President of Operations for MedImmune, and I'm also chairing the MedImmune's H1N1 Preparedness Committee. MedImmune's changed the landscape of influenza vaccination when we launched FluMist in 2003, representing the first innovative development in flu vaccines in over 60 years. This year, MedImmune has contracted with BARDA to deliver nearly 42 million doses of intranasal vaccine based on our FluMist technology. Between September and 2009 and February 2010, we plan to deliver those doses. The 42 million doses of H1N1 vaccine, along with fulfilling our commitment of 10 million doses of seasonal vaccine, represent an increase of 700% in MedImmune's vaccines production compared to last season. Importantly, MedImmune's manufacturing for H1N1 had no impact on our commitment to deliver 10 million doses of seasonal vaccine. In fact, we were able to accelerate seasonal delivery, and we delivered the first H1N1 vaccine this season to BARDA. Due to manufacturing efficiencies and high vaccine yields unique to our technology, the intranasal vaccine was the first available and remains a significant proportion of the vaccine available to date. We have finished the manufacturing of all 42 million bulk doses of vaccine, all of which is now on U.S. soil. We are now in the process of filling the vaccine in the specialized single-dose nasal sprayers. As of Friday, November 13, we have shipped approximately 13.2 million doses and are over 96% on track with delivering the orders BARDA has placed. MedImmune's unique technology provided a significant surge capacity for bulk vaccine. This success validates MedImmune's technology as a strategic asset in pandemic preparedness. As a result of MedImmune's excess bulk vaccine, we have submitted a proposal to BARDA regarding an alternative delivery device in order to further contribute to public health effort. The development and manufacturing process for our intranasal vaccine differs from that of the shot in several important ways. We develop our own unique master virus seed to grow the vaccine, while most of other manufacturers rely on CDC or other reference labs to generate the master virus seed. Critical to pandemic preparedness efforts is that we use a patented technology known as reverse genetics to rapidly create multiple strains, and then we can select one that grows well in eggs and has the other necessary properties too. Like the shot, our vaccine is also produced in eggs. However, unlike the shot, we generate between 60 and 100 doses of vaccine per egg. Longer term, replacing egg-based technology with cell culture manufacturing would be a key advancement for new influenza vaccines. In fact, we believe that cell culture technology used to manufacture intranasal vaccine will have similar yield advantages as the one I mentioned in the egg-based technology. MedImmune has an R&D program focused on the development of a cell culture-based vaccine. However, FDA requirements have increased the cost and duration of the development program by several years, and this program is now on hold while MedImmune and HHS evaluate the appropriate path forward. Now is the time to collectively evaluate what we have accomplished and what we can do better. It is critical that the US government continue to encourage high level of seasonal vaccination, as well invest in public education campaigns that increase awareness of the benefits and options in influenza vaccination. Additionally, it's key that the government agencies and industry jointly develop a blueprint for processes and requirements across a number of key areas, including, for example, clinical development, regulatory requirements, and distribution, to avoid any roadblocks that could delay delivery of vaccine in the future. In the few years that BARDA has been in existence, we believe they have done a remarkable job. MedImmune is pleased to be delivering intranasal vaccine in line with BARDA's expectations, and we look forward to building up our successful relationship in collaboration with the US government. I will be pleased to answer any questions.
Thank you, Dr. Mr. Hosbach. Your testimony, please.
Good afternoon, Mr. Chairman. Thank you for the opportunity to testify before the subcommittees regarding H1N1 influenza pandemic production, development, and delivery. My name is Phil Hosbach, and I am the Vice President of Immunization Policy and Government Relations for Sanofi Pasteur, and I'm currently responsible for coordinating the company's worldwide and U.S. pandemic response teams. Sanofi Pasteur is the largest manufacturer of influenza vaccine globally and in the United States, producing about 45% of the U.S. annual influenza vaccine supply. We are the only manufacturer of an activated flu vaccine on U.S. soil, and all of our seasonal and H1N1 vaccines for the U.S. market are produced in Swiftwater, Pennsylvania. This site, which includes 2 state-of-the-art influenza vaccine manufacturing facilities, and one of those was just licensed this year, as you heard from Dr. Goodman, they are operating 24 hours a day, 7 days a week, with more than 2,000 dedicated people involved in some way in getting the vaccine out the door. Many of these people have made great personal sacrifices to ensure that we produce the largest number of H1N1 vaccine doses in the shortest amount of time while ensuring vaccine safety and regulatory compliance. I would like to start my remarks today by focusing on what a remarkable achievement the U.S. response to this pandemic really is. Thanks to the close collaboration of industry with HHS, FDA, and CDC, we were better prepared for this pandemic than we would have been at any other time in history. The virus was identified in late April. Manufacturers received the seed strains from CDC in late May. Less than 4 weeks later, large-scale manufacturing was initiated, and by early October, there was an FDA-approved vaccine being administered. It truly is a success story. Nevertheless, we certainly understand the committee's interest in this process, as there are always opportunities to improve. Sanofi Pasteur began shipping H1N1 vaccine on September 29th, which was earlier than anticipated. We have received orders from HHS for 75.3 million doses of bulk antigen to be delivered by the end of the year. We will meet this commitment. While Sanofi Pasteur represents only 75 million doses of the 250 million doses purchased by HHS, I am proud to say we represent almost 50% of what has been delivered to CDC to date. Sanofi Pasteur has largely succeeded in producing the H1N1 vaccine as initially projected. However, there were some factors that impacted even our considerable abilities and extensive preparation. The most significant factor initially was the lower than expected production yield for the seed strain. It is an unfortunate fact of Mother Nature, but we sometimes see lower yielding strains even for seasonal flu. However, the initial yields for H1N1 were exceptionally low. Utilizing our expertise, we have been able to optimize the productivity of the seed virus. Our current H1N1 yields should not be a significant factor going forward. Since April 30th, we have participated in weekly phone calls with HHS agencies, including BARDA, CDC, FDA, and NIH, during which we provided ongoing updates. We've always been transparent about our progress. We now project that we'll not only catch up completely, but we may even be ahead of schedule in the coming weeks. The media coverage regarding H1N1 vaccine shortages have spurred some to question whether the egg-based manufacturing technology might be outdated. The egg-based vaccine production method we currently use has seen many technological advancements and is a very sophisticated process that has proven adaptable to emergency situations like the current pandemic. In fact, this year provides us with an opportunity to directly compare the availability of flu vaccines produced with egg-based technology and those produced in Europe using cell culture. In the end, each of the methods used produced clinical lots within similar time frames, and large-scale production was initiated at nearly the same time. Contrary to popular perception, cell culture is not a new vaccine production process. It's been around for about 25 years and does not save substantial time when it comes to producing influenza vaccine. It does not produce a safer or more effective vaccine and does not necessarily increase yields, which was a critical variable this year. The production of an influenza vaccine involves many steps, many of which are the same regardless of the technology or medium used. For example, growing antigen on any medium can only begin after the seed virus is isolated and is sent to manufacturers by CDC. Finally, no matter which production method is used, all vaccines must undergo rigorous quality control and safety testing. This testing accounts for approximately 85%, and I repeat, 85% of the production time. This year, Sanofi Pasteur faced the unprecedented and complex challenge of producing 2 influenza vaccines simultaneously. I am proud of the work of our people have done in ensuring that Sanofi Pasteur will not only meet its commitment to deliver 75 million H1N1 doses to HHS, but also meet its promise to deliver all 50 million doses of seasonal vaccine to its customers before the peak of the annual flu season. It is important to note that we still have a very long flu season ahead of us. Again, it is a credit to all involved that we've been able to respond as well as we have to this pandemic. While it is important and appropriate to discuss where improvements can be made, I believe it is equally important to recognize the accomplishments. Mr. Chairman, thank you again for allowing me the opportunity to testify, and I look forward to any questions.
Thank you. Dr. Lakey.
Chairman Stupak, Chairman Pallone, and members, Ranking Member Walden. My name is David Lakey. I'm the Commissioner of the Texas Department of State Health Services, and it is an honor to be here today. I've been in this position for 3 years and had the opportunity to serve in multiple public health events, including Hurricanes Dolly, Ike, and Gustav. My background is that I'm an infectious disease physician trained in both pediatric and adult infectious disease. And like members that have testified earlier, I have been affected by this. I was the first state health officer to be infected, and my family was also infected. History has taught us that pandemics occur, that the challenge is the timing and severity of the next pandemic, with the last one being 40 years ago. State and federal governments have planned and exercised their plans over many years. The challenge in 2009 was that this pandemic was significantly different than the high-severity pandemic that many of us had planned for. And it also occurred in our continent, and therefore we were having to respond as we were also figuring out this disease and defining its severity. Because of these differences, our state and nation as a whole had to rapidly flex our plans to match this situation. And this ability to adjust your plans according to what you see is a critical component to any successful response. And this flexing of our plans included modifying our plans related to the distribution of the novel H1N1 vaccine. Previous pandemic plans had anticipated a high-level, high-severity pandemic, and many of those had focused on mass vaccination clinics. However, mass vaccination clinics have many challenges, as I have listed in the information that I've given you. We've also looked at school-based clinics, and they have their own challenges, like I've listed in the information that I've provided. And so both of those strategies have significant challenges. In light of our real-world experience, Texas and many other states decided that we needed to adjust these plans related to the severity of this pandemic. We decided to use the private sector and the public health providers, the local health departments, the FQHCs that are in our state, as much as possible to provide the vaccine to the patients that they usually care for. This method allows us to target the vaccine to those priority populations. We've also worked with pharmacies and figured out how we could provide vaccine to pharmacies so they could provide it in that private sector. Now, different states are using alternative strategies based on their experience, their public health infrastructure. Public health is structured in many different ways across the United States, and the resources and the capabilities that each state had. In order to facilitate this, Texas had to develop new resources, new tools, in order for us to register providers and to pre-identify individuals within each priority population. And we made that web-based application and linked it to our primary flu information source at www.texasflu.org. Currently, we have 12,600 healthcare providers in Texas that are part of this distribution system. They've registered to receive vaccine. And of those, we've been able to apportion vaccine to 7,000 providers in our state. In order to complement the system, we have worked with H1N1 in order to address concerns from healthcare providers or from the general public in order to steer them to where we can find vaccine. Due to the limited supply that has been discussed today, states have had to further adjust these plans to help ensure that the most vulnerable individuals are protected. For example, Texas so far has been allocated 3.7 million doses. Of that, we've been able to order 3.3 million doses. However, that's the amount of vaccine that we were told that we would have available back a month ago in mid-October. Because of the limited supplies, we've had to target our populations based on risk and the type of vaccine that was available, and then gradually expand those groups as additional vaccine became available to us. I've outlined the system for the distribution of vaccine to providers in the state of Texas in the information that I've provided you. I note that once the FDA approves and releases a lot, the CDC informs the states about the amount and the type of vaccine that is available, and then a lot of additional work has to take place. We have to match the providers that we know that want vaccine with the vaccine that is available, ensure that they still want that vaccine, and make sure that they're ready to accept that vaccine. It is a challenge to match the current priority groups and to the providers that these populations serve, and we also have to ensure that we have good geographic distribution across a large state like Texas. This can be a complicated and a tedious process. We have been adjusting our plans as we have gone through this event, and recently we adjusted our plans to ensure that 20% of all the allocation that came to our state went to the local health department so they could fill in the gaps that that private provider base was not supplying. I'd like to finish my time by mentioning several of the challenges that we in state public health have faced as part of this pandemic. Note, this pandemic only occurred 7 months ago, and has been noted here, a lot of work has taken place across the United States in that relatively short amount of time. Furthermore, all this work was accomplished in a background of significant reductions in public health across the United States. We estimate approximately 15,000 public health positions have been eliminated over the last year across the United States. Now, despite this success, there's a national perception that we are falling short, partly because I believe we set expectations too high about the amount of vaccine that would be available initially, and the national supply hasn't been adequate to meet the public demand that was created. Additionally, we created the perception that vaccine would be available to all priority groups immediately. These priority groups account for almost half of the U.S. population. And because of the supply limitations, we as a state then had to narrow down those priority groups in order to get the best use of that limited resource. There's also confusion about that process of how vaccines are allocated, ordered, and shipped, and the steps that go into ensuring it gets to the individuals that need it. And there's differences between how the states manage that because of the different structures within public health in their state. These misperceptions have led to false impressions that states are either not pulling down their full allotment, or second, that they're not being allotted the amount that should be according to their population. And both of those impressions are false. There is also a challenge in developing tools to link individuals that are seeking vaccine with the providers that have the vaccine. And various tools have been developed, including web-based tools, but there's challenges with those tools, that the providers that we're shipping doses to may only receive a small amount of vaccine, and if we put their name on a web page, we may steer a lot of individuals to those sites and give another false impression that vaccine would be available, and I think that would compound the current challenges that we are having. Instead of doing that, we in the state of Texas have worked with H1N1 and provided them a list of the providers and have steered individuals to H1N1, and then we can give individual guidance on where they can seek vaccine in their community. And we've also, as I noted earlier, sent additional vaccine to the local health providers.
Please summarize.
Okay. I think we also have a challenge related to the public health has been funded, and that's been alluded to earlier today, the intermittent nature in which some of the funds have come down, one-time funding, and that's been difficult. But I'd like to say thank you for the funds that have been made available through the Public Health Emergency Response Funds this last year. Those have been very important. And finally, I'd like to say that we really appreciate the commitment of the CDC and the Office of the Assistant Secretary for Preparedness and Response for how they've engaged local and state public health. We have continuous dialogue with them in order to work out issues and figure out how we can best serve the population of the United States. Thank you.
Thank you, Doctor. Dr. Levy, your testimony.
Thank you, Chairman Stupak, Chairman Pallone, Ranking Member Walden, and Mr. Green. Thank you for this opportunity to speak to you today about our preparation and response to the 2009 H1N1 pandemic. I'm here on behalf of Trust for America's Health, a nonprofit, nonpartisan advocacy organization dedicated to saving lives by making disease prevention a national priority. While I understand that today's hearing is a result of considerable frustration with the current H1N1 vaccination program, I want to emphasize 4 critical points. First, the public health system at all levels of government has moved with remarkable speed in approving an H1N1 vaccine and getting vaccines to as many Americans as supply has permitted. We've moved as fast as or faster than any other country in the world. Second, the vaccine is well matched to the circulating virus. It has been proven to be safe and effective in clinical trials and offers the best possible protection against the disease. Third, whatever our concerns with production capacity are today, had the federal government not made the multi-billion-dollar investment in enhanced vaccine production capacity since 2005, we would be in far worse shape. The limits on supply we are experiencing are the limits imposed by the science and technology. The decision to use a central purchasing and distribution approach has assured that as supply has become available, it has been equitably distributed across the nation. And finally, the federal government has been remarkably transparent with the American people about this pandemic since it began last spring. Public health officials have leveled with the American people, making appropriate adjustments and recommendations as our understanding of the nature of the pandemic has evolved and as supply issues have arisen. The response to this pandemic has mobilized all levels of government. While the federal government has assumed responsibility for distributing vaccines to state and local health departments, each locality is then responsible for developing its own policies and systems for administration of the vaccine. This has posed a number of challenges, particularly in a context of vaccine shortages. First, local health officials received constantly shifting information about how much vaccine would be available and when. This is clearly an issue that has not only created confusion among the American people, it has also made the job of local health officials far more difficult. Second, the largest mass vaccination campaign in U.S. history is taking place when state and local health departments are experiencing devastating losses because of the recession. While the federal government has rapidly pumped almost $1.5 billion to state and local health departments for pandemic response, this does not address the underlying decline in the core capacity of health departments. And third, public confusion may well have been exacerbated by the fact that each state and locality has determined how to distribute its supply once received from the federal government. Although each health department based their plans on a larger supply of vaccine, HHS may want to revisit this issue and consider some standardization in future emergencies. It is our hope that this hearing will contribute to the public's understanding of the complexities of the current pandemic influenza vaccine campaign. Among the key initiatives TIFA maintains are critical to the success of the response to this and future epidemics are: first, an education campaign is needed to assure the American people about the safety and effectiveness of influenza vaccines and all vaccines in general. It is important to remind Americans that even with the delays in vaccine availability, they should get vaccinated as soon as they can. We have not seen the end of this pandemic. FDA should move forward in assessing new technologies that are already in use in other countries, including the use of adjuvants and cell-based vaccines. However, to have moved forward on an expedited basis without the standardized review would probably have undermined an already fragile confidence in the vaccine system. Congress and the administration should also come to a consensus on what is an appropriate level of investment in new technologies. This pandemic has demonstrated that the nation still has a long way to go, not just in vaccine technology, but with regard to diagnostics and antiviral treatments, as well as personal protection equipment. The Biological Advanced Research and Development Agency has been chronically underfunded since its inception. Its support is critical to moving promising developmental technologies into mass production. Professional estimates suggest that BARDA needs an annual appropriation of $1.7 billion rather than the current $275 million to achieve its mission. We need to provide ongoing support to state and local health departments in building capacity to respond to public health emergencies. Just as we don't fund fire departments at the moment a fire breaks out, we must move away from emergency funding mechanisms to respond to public health emergencies. This is one reason TIFA supports the mandatory funding for core public health functions that is part of the House Health Reform Bill. Finally, Congress and the administration should assure replenishment of the strategic national stockpile for supplies that have been distributed to states such as N95 respirators, surgical masks, and antivirals. We do not know what demand a future wave of this pandemic strain will require of the SNS, nor can we forget the potential for other pandemic strains emerging, such as the H5N1 bird flu that is of primary concern until last spring. This pandemic has shown both has shown our government at its best and highlighted many of the ongoing weaknesses in our public health system. As we continue to ramp up our response to this pandemic, we must also take steps necessary to assure that when the next public health crisis occurs, a stronger system is in place and capable of responding quickly, effectively, and nimbly. Thank you, and I look forward to your questions.
Thank you, and thank you all for your testimony. Dr. Narasimhan, how do you say your last name? Narasimhan.
Narasimhan.
Let me ask you about November 3rd. You signed a letter back to us, to the committee. We asked a number of questions of all the companies, the 4 or 5 companies here. And the one that had caught my eye was found on page 3. Point number 5, you said, while the government ordered bulk doses of our proprietary adjuvant, MF59, which enhances the potency of the flu vaccine and based on recently available data, could have quadrupled the number of doses supplied, the government ultimately determined that the use of adjuvant was not warranted to combat the pandemic and elected not to license or use the emergency use authorization. These are a number of the questions I asked the previous panel. It's my understanding, and correct me if I'm wrong, do other countries use your MF59 doses, which the adjuvant in it?
That's correct. We have two H1N1 vaccines licensed in Europe and in other parts of the world with MF59, and we're exclusively supplying adjuvanted vaccines outside the United States.
Okay. Is there a safety issue with it? I think the FDA said they had not approved it, and if my memory serves me correctly, you've been trying to get this approved in the U.S. since about 2007?
The MF59 is not approved in the U.S., but we've licensed it in Europe in 1997. We have a pretty broad range of clinical studies now, up to 200,000 subjects in non-controlled trials and about 40,000 subjects in controlled clinical studies. And to date, we have not seen any significant safety signals, so we've continued to provide that data to FDA on an ongoing basis.
Okay. Well, no, my 15 years here, I've always been on drug companies, make sure these things are safe. You said it's been licensed since '97 in the rest of the world?
That's correct, in the elderly. And then and for this H1N1 now, we have it licensed down to 6 months of age. So for the H1N1, the adjuvanted vaccines overseas are licensed from 6 months through the elderly.
Okay. I thought I heard Dr. Goodman, the last panel, indicate that they've ordered a stockpile of this MF59 from your company.
That is correct. We're maintaining a stockpile in Louisville, Kentucky.
And I asked him then, when were they going to use it? When do we get to the point where, whether it's adjuvanted or not, we're going to use it because the pandemic is so great here in the United States? Have they ever discussed that with you?
We had a discussion with them in early May as to how to proceed, and the decision at that point was to only use licensed platforms, U.S. licensed platforms moving forward. Through the summer and into September, we've maintained the capability to always use the adjuvant in case the clinical data suggested that was needed. We continue to stand ready to do that, but to date, and we also have prepared the EUA application in collaboration with HHS, but we have not been asked to date to move forward with that.
Okay. I think in your testimony you said you started discussing this in 2007, whether you should use adjuvant or not, with the FDA in 2007. You applied for a license in 2008. Is that correct?
We applied for a new drug application, IND, an investigational new drug,
okay, in
2008, and we've been going back and forth with the FDA since then.
Do you see this, the adjuvant issue, that just won't be with H1N1, but really any kind of a vaccine, isn't it? Because you can quadruple, at least in this case, at least quadruple your doses?
That's correct. I mean, there's a number of benefits from the adjuvant. One is you improve the immunogenicity so that if you have children or the elderly who don't respond, you can actually make them respond to the vaccine. You can increase the number of doses. Another valuable thing of the adjuvant, which was not as relevant in this case, is if the virus changes. So in the spring, if the virus changes, there might be the need to revaccinate everyone in the U.S., whereas with the adjuvant, you can cover a certain amount of variation in the virus we've seen in our clinical studies. Now, we haven't looked at that yet in this case, but it would at least provide you that flexibility.
Dr. Levy, is it fair to ask you, is it fair to say that this is something we ought to look at as a country? I mean, the FDA hasn't licensed it. I know you mentioned in your testimony about making sure drugs safe and approved, and that's my concern. I'm sure everyone's concerned on this panel. Are we missing something here? Is it something we should look at closer?
Oh, it's definitely something we should look at closely, and I believe the FDA is doing this in a good faith manner. I think, when you think about who we are targeting for this vaccine, the bulk of the data for using the adjuvanted vaccine occurs with the elderly. That's not who's targeted in this vaccine. And so we're just beginning to get the kind of data that you would be associated with kids. But I think the larger question is we have so much vaccine hesitancy in this country, so much inaccurate knowledge about whether vaccines are safe, and particularly whether this flu vaccine is safe.
Sure.
To add on through an emergency use application a new element that may indeed be safe could well have undermined the efficacy of this campaign.
Well, this one's been around for, as I said, I think 97 or so, and been approved. Would it be prudent to maybe leave the decision to the parent whether or not they wanted their child to be vaccinated with an H1N1 vaccine that's adjuvanted as opposed to not?
It is sometimes hard to understand why there is so much hesitancy around vaccines in general and this particular vaccine. I think we had a real public health question as to whether people would accept a vaccine that had a new product in it. Now, if things had been worse and this had been a much more severe pandemic, we may have needed to go that way anyway because whatever risk around hesitancy might have been overcome by fear of the virus itself. But I don't think that's where we are. I do believe that we need to move expeditiously in preparation for any future pandemic to be able to better address these questions about adjuvants and other technologies.
Okay, my time's up. Mr. Walden, for questions, please.
Thank you very much, Mr. Chairman. For those of us who don't spend our lives in the world you're in, could somebody give me like a 20-second explanation of an adjuvant? Doctor?
Sure. The adjuvants have actually been used in vaccines in the United States since the 1920s. There's one called alum that's been used extensively.
You might pull that mic a little
closer.
Sorry.
Adjuvants are actually additives that we put in the vaccine that actually boost the immune response. So in this case, what we would do is we'd make the vaccine as we normally would make it, add in the adjuvant, and then see how the vaccine performs. And typically, a lot less vaccine is needed, and the immune response is higher.
And in your clinical trials overseas, did I hear you say correctly that you haven't seen any adverse response? Well, maybe not any adverse response. You always have some, but nothing out of the band you would look at?
In our clinical trials, and I also just wanted to correct, we have now 25,000 subjects that are non-elderly. So it's not that we don't have data in elderly. We have quite a robust data set in the non-elderly population. We only see reactions comparable to seasonal vaccine for adverse events.
And when in 2008 did you apply to FDA for approval?
We did not apply, just to clarify, we did not apply for approval. The first step is to file an IND, and so we filed for the IND, which would then allow us to take the steps to file for the approval. Our intention has been to use our European data to try to move forward. The question always has been how much data needs to be repeated in the U.S. than done in Europe.
And when in 2008 did you do the first application?
I could get back to him in the exact date. I think it was mid-2008.
And what else do you hear from FDA that you need to supply that you haven't?
I think they would like to see adequately controlled randomized studies under FDA oversight that demonstrate the safety and benefit of the vaccine. We have a lot of data. Most of it's been generated not under FDA oversight with EMEA, European oversight. And the question for us as a company is how much of this can we realistically be expected to repeat? And of course, with flu vaccines being as profitable or not as profitable as they are.
Or as profitable as they are, which is to say they're not. Yeah. Okay, so going back then, well, let me run this on out. I mean, if this were the feared avian flu that we had hearings on and the potential of 4 out of every 10 dying because of it, I guess we would declare some sort of emergency and take whatever risk there is. But if you're using this MF59 in Europe and you're not seeing any real problems, I just wonder what it would take here to get going on that. What does FDA tell? We should ask FDA more.
Yeah,
I guess
I can't speak for the agency. I mean, my understanding is if the severity was such, or if the unadjuvanted vaccines had not worked, then they would have looked at this much more seriously. With H5N1, it's very difficult to get the unadjuvanted vaccines to work. So hence the MF59 becomes, adjuvants in general become much more important. In this case, because they had an unadjuvanted vaccine that worked, I think they were more reluctant to move with the adjuvant. And I would say that HHS and BARDA has funded a lot of our work with adjuvants, so the U.S. government has supported a lot of the work that we've done.
But looking at it from where you are today with the FDA, what kind of timeline do you think you and the FDA are on? And I realize they're your regulator and approver, and you have to, be really nice here. But I don't mean to put you on the spot. Just for my sake, the public's sake, what kind of timeline?
The way we look at this is we have an H1N1 adjuvanted, we have a seasonal adjuvanted, we have an H5N1 adjuvanted. Our goal is to get one or all, and ideally all of these licensed as soon as possible. And we would be willing, of course, to file as soon as we can find a pathway with FDA that makes sense. But I think we would be unwilling to repeat large clinical studies and incur all the costs again if that's what's ultimately going to be required, unless the government helped us.
Yeah. Are we the only country that doesn't allow the adjuvant in our vaccines?
At least for Novartis, the only country that we do not supply adjuvanted vaccines to is the United States.
All right.
So if I could just comment.
Yeah, go ahead.
CSL has a unique adjuvant as well that we developed in Australia. And we did put it into the H5N1 that we supplied to Australia during that time frame a few years ago.
And H5N1 is what?
That's the bird flu,
okay.
the avian flu.
Got it.
We also have multiple research programs going on with partner companies who are developing vaccines utilizing our adjuvant. And this adjuvant is being manufactured in Kankakee, Illinois. So we
manufacture it here, we just can't use it here.
It's being used in clinical trials with new vaccines that are being developed by other companies that we partner with.
And as you've used it in other countries, if I understood you correctly.
We've done the studies for H5N1 in Australia.
And did you find any outlier effects?
Be safe and efficacious.
Okay.
We're also able to produce MF59 in the Holly Springs facility, and we expect the MF59 suite in Holly Springs, North Carolina, to be operational in December.
All right. My time has expired. I know we have other members here who want to ask questions. Thank you, Mr. Chairman. Thank you to the panel.
Chairman Plone.
Thank you. I was going to use my time with Dr. Lakey here because you're the state guy, and I don't know if you were here when I asked the first panel, but all my questions were about distribution and also about funding because Dr. Laurie brought it up. Basically, you know that CDC has left it up to the states to decide how to distribute the vaccine. So I wanted to know how a state decides which entities will distribute vaccine, how many doses they receive, and essentially, do you agree with the CDC that these decisions should be left to the states, or should they be dictated by the federal government maybe a little more strictly? I mean, I know they have guidelines, but I don't know if you were here before, but I've been getting all these criticisms in New Jersey about the Wall Street firms getting the vaccine because they can distribute it better or, than some other places. So, and we're hearing in my own state of New Jersey and in New York about, major disparities. One school district versus another gets it. One gets it, the other doesn't. Well, I just want your response. I mean, I know you're a state official, so you probably think states are great, but I'd just like your response.
Sure. Let me provide some background related to how we do this. We have the ACIP guidelines of the high-risk groups, and then those were further prioritized into a group taking it from 159 million to about 49 million. And so the challenge for us has been the changing landscape and how much vaccine is going to be available, because your strategy to deliver vaccine changes depending on how much vaccine you have. You can't run a mass vaccination clinic if you only have 100 doses, and you can't provide a school-based clinic if you're not immunizing healthy young kids. And so states looked at those priority groups, and I think most states looked at healthcare workers, pregnant women, and very young kids as those top individuals that we needed to start our immunization program with. The challenge was that the first vaccine that was available was the nasal spray, and so we couldn't immunize pregnant women with the nasal spray, and so we had to wrap.
And just to interrupt you, I've had that phenomena too, where, you know, one of my school districts has the nasal spray,
Yes.
but doesn't have the vaccine, and they want the vaccine instead of the nasal spray.
Yes, yes. And so it's a matching of the vaccine that you have available with your priority groups and your distribution system. What systems do you have available? And so a lot of us state health officials tried to move from large vaccination clinics to using the private sector. You know, it's one of the challenges with the large.
So you use the state, you use employers as well, the way New York does?
We're not used, well, we're providing it to the physicians, the healthcare systems.
So you don't actually, I know I'm interrupting, but I'll run out of time. You don't actually do like what New York has done, or maybe New York City has done, where they would go to large employers like Citigroup or Goldman Sachs that have health clinics and have them do the distribution.
I have 13,000 registered providers on our system, and it's a combination of many of those. There may be some occupational health, but that's the minority. The most of these are pediatricians, OBGYN, family practitioners in the state.
Would you, do you think that, I'm asking you to criticize another state, but I mean, would you, New York obviously uses some of these large employers. Do you think, does that make sense?
Well, I don't know the details
of
New York. From what I have gathered is that they've been trying to meet the priority groups and trying to reach pregnant women in different ways that they could do it. But I cannot speak for the state health officers with that.
All right, let me issue this. You did mention the challenges of intermittent public health funding, and Dr. Lurie brought up funding challenges. I was a little critical because I don't remember the secretary mentioning that when she was here. And of course, you know, if you need money, this is the place to come, for the most part these days. Talk to me a little bit about that. I mean, to what extent the lack of funding or intermittent nature of it has been a problem?
Sure. I think there's a couple of issues here. One is the federal funds that have been made available. You know, after 9/11, a lot of funds were made available. It peaked, and then it gradually declined. And so we receive now probably about half of what we were receiving earlier on. We also had, in 2006, one-time funding related to pandemic flu. And so that money was utilized to put together plans. But you can't hire people for long-term on one-time funding. And so that funding went away. Those plans were made. But you can't continue that process after those funds have went away.
But you obviously feel that it makes sense for the states to have a lot of discretion here. In other words, you wouldn't suggest that the federal guidelines be strengthened or made more detailed at this point. You believe the states should have the leeway to pretty much do what they want pursuant to the existing guidelines? I
guess the clarification, that's for the folks that are being vaccinated right now, the guidelines.
In terms of the distribution.
The distribution system. I think where we are right now, folks are titrating up those groups. I think they based that on their capacity as a state. What were the resources? What was their history with delivering vaccine? And then they used those systems. And so you have public health is structured many different ways across the United States. And they used that uniqueness of their system, who they could reach the quickest in order to determine their priority groups, using the same basic philosophy, trying to get pregnant women, young kids, healthcare workers from the beginning, but then how they massaged that and adjusted that was dependent on what that state system was.
All right. Thank you. Thank you, Mr. Chairman.
Mr. Shimkus for questions, please.
Thank you, Mr. Chairman, and thank you for the panelists for being here. You know, we've spent a lot of time on Adjuvant and how it boosts this, but I want to focus a little bit on this, the nasal spray. And so, Dr. McKelson, I know in your written and opening statement, you mentioned this, I guess it's intranasal technology, and the ability to get 80 to 100 versus 1 through 7 doses. Can you explain that to us and why that's, I mean, if we're talking about needing a lot of doses from the layman's point of view, it sounds like a good thing to be focusing on. Yeah, I can explain that. I think there are two reasons for that. One is I think we at Medimune, we develop our own seed strain, and using the reverse genetics, we can quickly screen multiple variants of the vaccine and select for growth properties, immunogenicity. So for instance, for the H1N1 vaccine, we basically screened 23 variants and did not lose any time, and we were in commercial production at scale on July 3rd. I think the other important factor is so we were able to actually immediately create an H1N1 strain which produces as much as we have seen in the past. And then the other advantage of the live attenuated technology is actually you spray it in the nose. You have the virus replicates there and creates a immune response. So if you compare it to the inactivated vaccine, you need a very, very small dose. Maybe if you compare it from, let's call it quantitative factor 50 lower. So I think that is a very important attribute to actually consider this technology as part of pandemic preparedness. I can tell you we have manufactured over 100 million bulk doses, and we could easily have gone up to 200 million doses by bulk doses by the end of this year.
And what piqued my interest was also some of the comments when Chairman Pallone got into the discussion a little bit, and the nasal spray issue is not for pregnant women, but there's a lot of other, I mean, the other two groups, there would be no prohibition for them. Is that true?
That's correct.
So I think he mentioned a school that didn't want to do nasal spray.
I think that we are not, we do not have pregnant women in our label, and we cannot administer the intranasal spray to that population. But the majority of the risk population is covered by the intranasal vaccine. So I think what's also very important is that there is enough education to actually objectively make people aware of the choices available in the flu vaccination technology. Because maybe people now react on the intranasal vaccine, but there may be a same fear factor for the adjuvanted vaccine. And I think those assumptions in the public could be avoided by a targeted education campaign where it is emphasized that the safety and efficacy of the general vaccines available in the U.S. is good.
Thank you. Dr. Lakey, the title of the hearing is an update on vaccine production and distribution. And when I initially read that, I always think distribution is, can the drug get from point A to point B? I think what a better title for this would have been in the decision-making matrix of who gets it. Not, for me, there's no distribution problem as far as you see of when this is produced to a delivery to an endpoint user, is there?
For the most part, no. I mean, there is. So that is in the private sector. It is manufactured. It is, we order it and it is shipped. That system seems to work for the most part. There have been weather events, et cetera, that have slowed that down. But for the most part, that distribution system has worked.
What else do you think we need to do? Because you probably listened to the opening statements. My concern is if we can't get this right, how do we do something? What do we need to do to prepare ourselves better for H5 or something that may turn out to be a bigger problem?
Well, I guess I've learned through other events, such as hurricanes, et cetera, that you have to take time afterwards to critically look at what went well and what you could have done better, just learning from your experiences. I think there's been good discussion today of what we can do to improve the availability of a vaccine. I think making sure that we communicate effectively to individuals real expectations and not set artificially high expectations, because I think the general public will respond when we're given the right expectations.
And I agree. My time's expired. Thank you, Mr. Chairman. Thank you, panel.
Thank you, Mr. Shimkus. Mr. Green, for questions, please.
Thank you, Mr. Chairman, and Dr. Lakey, I appreciate you being here, and glad we got to meet earlier. And appreciate what you've done for 3 years as the Commissioner of Health in Texas. And I guess one of my interests is on the delivery system, although our big issue here is why we don't have enough vaccines, obviously, and I know you experience it every day in Texas, like a lot of us here from our offices. But one of the challenges you mentioned is associated with school-based clinics and vaccinations. And I noticed in today's Houston Chronicle, some of my school districts in the Houston area are actually doing it. Alief, Humble, and I was wondering, are you having any resistance from schools, particularly schools that have school-based clinics, to providing the H1N1 for their students?
I think what we're seeing in Texas is a mosaic of different strategies working together to get individuals immunized. I think some schools, there are school systems that have a lot of experience with school-based clinics, and those seem to work. There are other school systems that haven't done that well, haven't done it in the past. There are some challenges making sure that you get parental consent, so you don't immunize a child that hasn't provided consent, the parents haven't provided consent, and other just logistical challenges. There are folks that you have to have there to provide immunizations, et cetera. We are using some of the funds that were provided by Congress to be able to hire individuals to allocate that. But all those things have to come together. So that's one part of our system. We're able to do that now in Texas because as we've titrated up the number of groups, we've been reaching the high-risk individuals, the children with asthma, et cetera, and so we're now able to expand out to some of the healthy kids in our state.
Okay. Can you tell us how public health emergency funds help you and other state public health departments set up and operate the H1N1 program?
Excuse me again, sir?
How the public health emergency funds that you receive help with that?
Yeah, the public health emergency funds came in 3 components, and they've been critical to our ability to respond. The first part had to do with getting surveillance systems. Again, public health has been cut, and so having feet on the ground in order to investigate cases, figure out whether this H1 or not, that's been critical to hire those individuals. We've been able to improve our laboratory capacity, having the individuals in the laboratory to process samples. That has been a critical component of our system. We've been able to develop the vaccine ordering system in order to make sure that we have that technology in order to accomplish this. About 81% of the funds that came in, Public Health Emergency Response 3, we sent out to the local health departments and so that they could hire the individuals to be able to respond. Again, there's been significant cuts at the local level in public health. A lot of those public health departments are shrinking and can't provide that investigation, the delivery of vaccine, all those different manpower components without the funds that were allocated in order to hire those individuals.
Dr. Levy, I know you released a report co-authored with American Academy of Pediatrics, states that school-aged children are the population most responsible for transmission of influenza and highest rate of attack. And that report also cites in 2005 a school-based pilot program in the state of Maryland where flu mist was administered to children in several Maryland secondary and elementary schools. And the results were that the program showed significant reduction in respiratory illnesses within households of children who receive these vaccines versus schools that do not participate. It seems like that report, and I'm sure there's others, proof that shows school-based facilities, of course with the parents' permission, but that making it available to parents is a successful way to deliver that.
Absolutely, and certainly using school-based facilities for both immunizations and other types of health care are critically important. That's why there are some major provisions in the health reform legislation that would expand that capacity. This is a tremendous opportunity to reach kids, and a lot of our pandemic planning assumed that kids would not that it would be more like seasonal flu, and the elderly would be most vulnerable. As it turned out, young kids were the most vulnerable, and so if we had a strengthened school-based clinic and immunization program, we'd certainly be in better shape today.
Okay. Mr. Chairman, I appreciate my last question actually for the reason we're here today, and it's to ask our producers of the vaccination. I know there's been a lot of discussion regarding benefits of new technologies and to produce flu vaccines, and the cell culture is the newest one. But I understand that there's no difference. We wouldn't be producing faster vaccines using cell as compared to the eggs? And if each of you, as brief as you could, respond to that. Is there something we could do that would make it quicker, whether it's eggs or the cell?
I think, cell culture is not a game changer. I think I'll steal that phrase from Tony Fauci. The game changer probably is really something along the lines of a universal flu vaccine, which you could stockpile. It covers all different variants of flu strains over the course of seasons. However, that's a long ways away. In terms of saving time, whether it's cells or eggs, you're again dealing with Mother Nature. You have to adapt the virus to the system that you're utilizing. And perhaps with cells, maybe you save 2 or 3 weeks. But in terms of capacity and overall production capacity, I don't think that it's really a game changer. You'll get virus out there, vaccine out there at about the same time. In fact, the 2 facilities that we have based in the U.S., they have the potential to produce 150 million trivalent seasonal doses. If you convert that to a monovalent, that's 450 million doses of an H1N1 type vaccine. So there's plenty of capacity right here on U.S. soil with the one new facility in our existing facility. What we really need to look at is, why aren't we immunizing as many people as we should be immunizing on a seasonal basis? When 36,000 people die every year and 200,000 people are hospitalized, we have recommendations from the ACIP that 275 million people should be immunized on an annual basis. We're lucky to immunize 100 million people. If you want to sustain influenza immunization, production, development of new technologies, we really need to make sure we get more people immunized for the benefit of public health and for sustaining our manufacturing capabilities.
Okay. So the capacities here, whether it's production in the United States and I know we have one production in Australia, which is fine, but we have the capacity to produce 400 million vaccine for H1N1?
I think there's an important dynamic here. So for this vaccine, but what we saw with the avian influenza is that an unadjuvanted 15 microgram dose was not sufficient. In fact, many manufacturers saw it took 90 micrograms, right, which is 6 times as much, which means the supply collapses. And so as the only manufacturer here that actually produces cell culture-based vaccines, we actually have 2 licensed cell culture vaccines now in Europe. We're producing it for Europe, unadjuvanted and adjuvanted, seasonal and pandemic. And what our belief is with cell culture is you get some speed gain. Our expectation, a little different view, is that it's on the order of 6 to 8 weeks, but it's not massive. I mean, it's going to be on that range as to the gain you get with cell culture. But as Dr. Michelazi also mentioned, with reverse genetics and using some new technologies, cell culture allows you to actually meet the need of many of the changing viruses that are out there. And the worst case scenario for the American public is you rely on a single technology. That technology doesn't work when it's a different influenza strain, and then suddenly you have a real crisis on your hands. So I think it's a wise strategy to invest in multiple different technologies, simply because we don't know how any one virus will behave.
Okay, quickly, because again, Mr. Burgess, we're going to have votes here soon.
For us, the eggs are working well, but I think if you can have the cell culture technology also available, it de-risks the supply in the fact that if you have a really bad avian flu going around, it may affect the supply of eggs and those kind of things. I think the scalability of cell culture technology is very critical, and I think especially if you think about the live attenuated flu technology, we have a facility in Frederick, Maryland with 2 2,500-liter bioreactors. With the cell culture flu intranasal technology, we could manufacture half a billion doses in that facility. And if you think about the cost efficiencies you could generate, I think the cell culture at scale could be a very interesting asset and guarantee or further guarantee supply of flu vaccine.
Thank you. Mr. Burgess, for questions, before you start, I should mention that you're one of the members that had written to myself and Chairman Pallone and asked for this hearing, and along with other members, but we appreciate it, and we'll start with the questions.
You're kind to point out that I didn't whine. And, you just finished up on an excellent point, Doctor. Mike Levitt came and testified here in, I guess it was 2005. It was going to be very, very difficult to develop the number of eggs that would be needed to produce the vaccines if we'd culled all our chickens the month before. Let me just ask a couple of questions of all 4 of our manufacturers, and I'd appreciate brief answers. But when in this sort of the timeline that's been going on since last April, when did you find out about the delay? When did you really appreciate we were a month behind?
Well, I'll respond first. I think that we did not, because we did not participate in the pandemic RFP that was put out by the U.S. government a couple of years ago, our contract was a bit different. So we started the negotiation in May and finished in May, which is the fastest I've ever done a government contract, by the way, which was quite nice to see. And we had to submit at that time our schedule that we assumed based on average yields when we signed the contract. Within 3 weeks, we could see that the virus was not growing well. So we started at the beginning of June, and we could see that the seed strains that we had were not developing. In fact, they were a half to a third of what we had expected. And again, our expectations were set on 10 years of seasonal assays. But as all of the manufacturers here will tell you, each new flu season is a new flu season. Right. You just can't tell, and I think you have a medical background as well, or physician, so you understand that. But I think that we knew right away. We had weekly conference calls with HHS and BARDA, and we informed them and put a new delivery schedule together in July.
You did communicate through conference calls?
Yes, we did.
And that would be in June?
We communicated in June and then put a new delivery schedule together in July, based on our assumptions.
What was Novartis's experience?
With Novartis, we saw the reduced yields in July. And I just would point out, for clarity's sake, we actually can't confirm yields until we receive FDA reagents, and those reagents were really made available in August. But with initial testing, we saw the reduced yields in July. We communicated our situation weekly with HHS, as did all the manufacturers.
Well, MedImmune is different, but what about Sanofi?
So actually just the same for us in terms of realizing that we first started out on a very conservative estimate in terms of yield of the virus, and it actually was about 60% of what we thought it was going to be, even on a conservative number. And we had weekly phone calls with BARDA, HHS, and schedules were revised all throughout the way periodically as we gained new information.
Well, I'm a little concerned because I had some conversations in August with CDC and NIH and was given assurances that when school started, we would be well on our way to having, depending upon the approval process, well on our way to having satisfactory doses by mid-October, and that was kind of the timeline that I was laboring under. Let me ask you a question. In the end of October, Secretary Sebelius, at a Senate hearing, said she was going to put out a call to the manufacturers to accelerate production, but I'm going to assume you'd already done so at that point. Is that correct? Was there anything you did differently as a result of that call?
At CSL, what we did is, when we did receive the call, we took another look at our ability to fill and finish vaccine. Producing the antigen is one piece of it. Then you have to actually get it into a formulation and put it into either vials or syringes. Our manufacturing plants for fill and finish of flu vaccine are inside plants that produce other therapies. So our CSL business includes protein plasma therapies for rare diseases. So we had to adjust our lines and our manpower in order to see if we could free up some manufacturing slots.
And you did that as a result of as a result of the call on October 29th?
We did. We were evaluating all along the way, but that was also a call to reinforce what we had been discussing with BARDA.
Let me just ask if any of the manufacturers, was it problematic for you that you were at the point where you were gearing up for the seasonal flu and you then suddenly had this H1N1 task added to the equation?
I think it was just the compression of the timelines. We had to complete our seasonal flu, at least for the case of Novartis, complete our planned seasonal flu doses, which was what we were requested to do. And then we started, in our case, H1N1 in July, which obviously brings us have a very short time frame, a short runway to sort of get the plane off the ground.
But still, there's been difficulty getting seasonal flu vaccine out to. I know our community has been lacking for several weeks. Are we back on schedule with the seasonal flu?
Well, in our case, we completed our seasonal deliveries in early October.
Completed them, but the house physician here is out, for example. My Walmart back home is out. I know I could get the MedImmune, and I should do that. But for the other vaccine, in our area has been harder to come by. And I know Dr. Lakey may know more about what difficulty we're encountering there. Let me just ask MedImmune on the issue of adjuvants. Are there adjuvants that you use with your with your attenuated live virus?
We don't use any adjuvants in our.
Because your yield and the method of immunogenicity is such that the yield is so high?
It's a live virus, and it replicates in the nasal cavity. You don't need an adjuvant.
Dr. Lakey, let me just
want to highlight that we completed our seasonal manufacturing also in time, and we're even able to accelerate it so to free up more manufacturing capacity for H1N1.
Dr. Lakey, thank you. Dr. Lakey, let me just ask you, because, Texas has had some problems, and some of them have made their way into the front page of the newspapers. But when did you learn that Texas was going to be having some difficulty delivering on the vaccine shipments?
Yeah, I think we learned as vaccine was coming out that it wasn't what we had anticipated, and so in early October, as I recollect, was when we figured out that what we were being told we were going to get was not what we had been told in the past.
Do you feel that CDC and HHS shared information with you in a timely fashion?
We've had multiple calls with the CDC and the Office of the Secretary of Preparedness and Response, and they showed predictions, but a lot of them changed pretty quickly.
Now, have they been helpful in helping you adapt to the change in the vaccine availability?
The CDC has been very helpful to us in the state of Texas when there have been issues that have arisen. We have called them individually. We have conference calls 2 times a week with their leadership with all the state health officers to discuss issues and to have a question and answer time period. And so they have been available and have answered questions. And
how about the manufacturers themselves? Have they similarly responded with information when you needed it, or do your communications go directly through CDC?
My communication would go through the CDC. The manufacturers would discuss that information with the CDC. So there hasn't been a direct conversation between state health departments and the manufacturers.
And you and Mr. Pallone talked a little bit about funding. Do you have I get the feeling that the level of funding, the $1.5 billion, was not satisfactory. Do you have an idea in mind of what would bring us to a level of funding that would be satisfactory?
So this is for the FER funding right now. There's the Association of State and Territorial Health Officials talked to state health officers to figure out what they think they would need. That survey thought that about $800 million would need to be available in order to continue this response through March. Some state health departments are in better shape than others. Some, I believe about half of them, are predicted to run out of their FER funding by the end of this year. And so you have, again, state health departments are in different situations, but when we've tried to look at this systematically throughout the United States, the number was about $800 million to get all state health departments through the end of this pandemic.
Now, you've indicated to me that you see that the number of cases is actually diminished over what it was even just a few weeks ago, and yet we're coming up to the holiday season between Christmas and Thanksgiving and Christmas. People will be traveling a great deal in this country, and I just remember my days in the clinics, you'd typically see a great increase in viral syndrome around Christmas time and the weeks shortly after. Now, could we anticipate a resurgence of the number of cases toward the end of the year because of the amount of travel that people are going to be doing?
That is correct. And so as a state, we monitor the percentage of visits to physicians that are for influenza-like illness. We peaked in Texas around 13%. We've gone down to about 7%. But the nature of pandemics is that they occur in waves, and we predict that there will be a third wave. The challenge will be how that third wave corresponds to the seasonal flu. And we hit one and then the other, or do you have seasonal flu on top of H1N1, which would be a challenge for state health departments.
And since
Mike, I got to wrap her up. But you're
just as a final thought, of course we're right next door to Mexico, which is where this began a year ago. Is there any thought to what might be happening to the evolution of the pandemic in Mexico? Will they be on their second or third or fourth wave in February or March, around the same time frame that this was introduced last year?
Yeah, I don't know if I can intelligently answer that. I think we would predict that they are going to have an additional wave. I think what we've one of the challenges for us is is there a correspondence between the severity and social economic factors? And so in poor areas of our state or in poor countries, do we have more significant disease? And so we're wrestling with that currently.
But it definitely impacted us last year when they became ill. We developed symptoms very quickly in our state.
Yeah, infectious disease do not respect borders, and it came across our border very rapidly. Throughout the southern part, the hardest part of Texas, the part of Texas that was hit the hardest was our southern border. If you look at our fatality rates, et cetera, there's a significant difference of our border versus the rest of our state.
Thank you, Doctor. I'll yield back, Mr. Chairman.
Well, just in summarize, we're going to have votes here in a few minutes, and we'll finish up with this panel and finish up this hearing. Dr. Lakey, it's fair to say we're going to get another wave of this H1N1. Right now, it seems like we're at a calm before the storm, and is that because there's more vaccines out there, or is it what is it? We're going to get hit again, are we not?
I'm not sure if it's there's probably several factors interacting. One, the natural history of pandemics coming in waves. And I think that's what we're seeing. And you'll see differences across the United States. Activity is decreasing in Texas. It's rapidly increasing in other parts of the state, in the New England part of the nation. But the natural history of pandemics is that they occur in waves. And so our goal as we vaccinate individuals is that we can blunt that third wave. And that's why it's not too late to immunize individuals, even though this wave is decreasing, that we need to blunt that third wave.
So, as Mr. Burgess said, as we move about during this holiday season of Thanksgiving and Christmas, that could very well spread it in areas that has not seen the intensity we've seen in other parts of the country.
As we get into the colder season, as people are more inside, as the humidity changes, as the environment is more conducive to the spread of infectious diseases, it is likely that there will be additional spread.
And then we could very well have the seasonal flu on top of it.
Exactly, sir.
Okay. Well, let me just ask you all this question, and just to summarize, it's my understanding from listening throughout this hearing that there really was a pretty good cooperation or with the government in working this one out between communications, coordinations, and even moving some contracts fairly quickly. Is that fair to say? I mean, we're usually on the government, but I mean, it sounds like this time they actually, all the preparedness they've done for a pandemic has actually worked out fairly well. Is that fair to say? You're all nodding your head yes? Okay. Mike, any other question before we close her down? Wrong question to ask.
I am disturbed because Secretary Sebelius did indicate to us that we would have the doses that we needed. And again, my calls to the CDC and HHS, although they were off the record in August, yeah, I got the information that they'd studied what was happening in the Southern Hemisphere. It wasn't as bad as what they thought, but there were certain populations that would definitely be at risk. But not to worry, we would have the vaccine done and approved and in the hands of the providers certainly by mid-October. At that point, the fear was, what if it's worse when the school year initiates, so the 1st of September, and we have to push this stuff out the door before the clinical trials are finished at the end of September. So I'm still uneasy about all of that timeline. And my very first statement of this was when I had that very first conference call, I was worried that we were going to underestimate the severity of this virus. And I mean, it's just incumbent upon us to constantly stay vigilant and not get complacent about our ability to fight it off.
There's no doubt we had rosy forecasts from the Secretary that has not held true, but I think between the low egg production of the virus and condensed timeline and the great demand has probably led to the frustrations that we all feel, and that's the purpose of this hearing, to get to it. And I think we learned a lot from this panel and the previous panel, but overall I think the government cooperation and working together and try to resolve this has been pretty good, probably above par. So with that, let me conclude this hearing. That concludes all questioning. I want to thank all of our witnesses for coming today and for your testimony. The committee rules provide that the members have 10 days to submit additional questions for the record. That concludes our hearing. This joint hearing of the Health and Oversight and Investigation Subcommittee is adjourned.
Nice to meet you.
Nice to meet you. Good job.